Hi, everybody. It's a privilege to have you all here, as well as our wonderful four speakers. We have terrific topics tonight. And before I introduce those topics, I want to talk to you a little bit about breast cancer in general. We treat a lot of breast cancer. We treat a lot of people who are at risk for breast cancer. And we have many surgeons across all the campuses from Long Island to New York City to Brooklyn. And it's really an enormous privilege to be able to work with everybody. So you're going to hear from four of our terrific surgeons. Dr. Schnabel is going to talk about the prevention and screening tips, the 10 top. Dr. Pack will talk to us about what genetics tells us. Dr. Anthony Baez will talk to us about eating to reduce breast cancer risk and a little bit about alcohol and exercise. And Dr. Amber Guth is going to close it with the top 10 questions to bring to your doctor. So we'll start with the top 10. We'll end with the top 10. Breast cancer is really a heterogeneous disease, and how your neighbor gets treated may not be how you get treated. Female breast cancer represents about 15% of all new cancer cases in the US. It's about 300,000 new cases a year, and it is the second most common cancer in women, the first being skin. And the lifetime risk of developing breast cancer, about 13% of women will be diagnosed with breast cancer at some point during their lifetime. You know, it's a disease of aging, so the older you get, there is an increased risk of developing breast cancer, and the median age of diagnosis is 63. But the very good news is that far more people get diagnosed with breast cancer than die of breast cancer. This is a 5-year survival of women or all comers of those diagnosed with breast cancer, almost 91%. So the green figures are those who survive breast cancer at 5 years, and the gray figures are the ones that have died from breast cancer. But again, what you need to remember is far more people get diagnosed than succumb to breast cancer, and that's an important point that you should bear in mind, especially if you are diagnosed with breast cancer. And let's talk about the survivors in the United States. In 2020, there are almost 4 million women who are diagnosed with breast cancer who are living full lives. Of course, you know, some of them are living with the long-term effects of treatment, and we're working very hard at trying to allay those symptoms. We run some survivorship series by Dr. Marlene Myers. So if you haven't had any contact with that and you are a survivor, you should look into it. We have a great website. So our first speaker is Dr. Freya Schnabel, who's the director of breast surgery at NYU Langone Medical Center and a colleague.
So the topic that I'm going to talk with you about tonight is about screening and prevention of breast cancer. And it was really hard to reduce this to 10 tips. So I'm going to try to phrase this and frame this in the context of some really important takeaways. And at the end, I'm going to try to give you 10 things that I hope that you're going to remember from this presentation. Next slide, please. So first of all, let's do some definition. When we talk about prevention, that relates to efforts to reduce the incidence of a condition or disease. That's primary prevention, to reduce the number of people who are affected by that disease. Screening is different. Screening refers to interventions that identify a disease or condition at the earliest stages, and because the condition is diagnosed early, the negative effects in terms of people succumbing to the disease or succumbing to the consequences of the disease are reduced. So when we screen for breast cancer, we try to diagnose the disease early when the results of treatment will be better and more people will survive. So let's talk about screening first, and we'll talk about prevention second. As has already been pointed out, breast cancer is a very common disease in American women, and about 40,000 women die from breast cancer every year. So clearly, this is an important public health issue that has great impact on the American public, both on the people who are affected by breast cancer, their families, the workforce in general, et cetera. So when we focus on detecting the disease early, we want to improve the prognosis, we want to improve the patient's outcome, but in addition, and very specifically with breast cancer, screening for early detection allows the patient to have more appealing, and as I like to say to my patients, less obnoxious treatment options. And that is another additional and very meaningful benefit of screening. Now, in order to think about screening in the right context, we think that all adult women should have some effort made toward the assessment of their personal risk to develop breast cancer. And this analysis of breast cancer risk includes both elements of personal history and family history. Personal history can include things like prior breast cancer or a diagnosis of conditions that are known to be associated with a high risk of breast cancer, like atypical hyperplasias. And also, and I think everybody is probably very familiar with the impact of family history on increasing someone's risk to develop breast cancer. Now, thinking about this and concentrating on breast cancer risk assessment is really important. It allows women to be referred for genetic testing when appropriate, when there is really a possibility that they will be found to carry an abnormal gene that may increase their risk. And also, this risk assessment allows us to develop individualized programs for breast cancer screening and prevention that are specific to the individual's risk for the disease. So when we talk about screening for breast cancer, there are actually a couple of elements to this. And some of the elements of screening have to do with what the healthcare system does for you, when your doctor examines you, when you undergo breast imaging, et cetera. But there's another part of screening is part of what we can do for ourselves that don't require a visit to the doctor and that we can take on our own. So breast self-awareness is something that allows us to think about our own understanding of the way that our breasts appear. We need to be educated to understand what is normal and what is not normal. And this allows us to recognize significant changes when they occur. The analogy I like to present here is that I think the American public has become very familiar with the idea that if you have a mole on your skin that changes color or bleeds, that's something you need to bring to the attention of a doctor. Same thing with the breast. There should be signs that we shouldn't neglect and shouldn't ignore and should bring to medical attention. So what are some of those findings that an individual woman can recognize on her own that should be brought to medical attention? Any change in the skin of the breasts or the contour, including dimpling of the skin, retraction of the skin, change in the color or the thickness of the skin, can be a sign of breast cancer. Spontaneous discharge from the nipple, particularly if it's bloody, should also be brought to medical attention and needs to be evaluated. It doesn't always mean cancer, but sometimes it does, and it really needs to be investigated. I think something that's pretty commonly recognized is that a mass in the breast in an adult woman that persists over time should also be investigated. It's really impossible to tell just by feeling a mass what the nature of that mass is. Is it a fluid-filled cyst that's benign, or is it a solid mass that needs to be investigated and possibly biopsied? Now, this is something that can be difficult, especially in young women when the breasts are lumpy. It can be hard to tell if what you're feeling is a real mass in the breast or if it's just normal lumpy tissue. So here are my couple of tips on that. A mass in the breast that requires investigation has three characteristics. It's persistent, it's consistent, and it's defined. So what do I mean by that? Persistent means it's here today, it's here tomorrow, it's here the next day. It doesn't go away, especially if you can follow it through a menstrual cycle. Consistent means it's always in the same spot. The breast is not liquid, things don't move around. You should be able to pinpoint that area every single time. It should be in the same zone. And defined means that there's a boundary, there's a border. You can see where it begins and where it ends. And if you have a mass that satisfies these criteria that you find on your own, that should absolutely be brought to medical attention because it requires further evaluation. Now, screening also involves the healthcare system. And the foundation for screening for breast cancer, besides clinical exam by your doctor, is breast imaging. And there are three main types of breast imaging that we use for screening: mammography, breast ultrasound, and breast MRI. Of all of these, mammography is the one screening modality that we know, if you do it regularly as a mature woman, it can decrease the chance of dying from breast cancer. And this is the one imaging modality that we have that level of evidence for. But mammography is not perfect, and we understand that especially when women have dense breasts, mammography may not be that sensitive a screening tool, and in that context, it may suggest that supplementary imaging like ultrasound can be very, very helpful. And in certain situations, particularly the very highest risk women, breast MRI can also be used for screening. Now, the guidelines about screening mammography have been a source of great contention over the last decade or so. And some of us will remember when those guidelines were revised a number of years ago, and there was a lot of discussion and potentially debate about what the guidelines should be and what the recommendations should be. But at this point, we now have, again, some clarity, and the U.S. Preventive Services Task Force recommends annual breast cancer screening beginning at age 40 for baseline risk individuals. So no family history, no other risk factors. We're back to annual over 40 because we recognize that women in their 40s do have a risk of developing breast cancer that's meaningful, and we need to screen those patients. However, we also recognize that the choice of how an individual woman should be screened needs to be influenced by her age, by her risk for breast cancer, and by the density of her breasts as determined by mammography. Age, Dr. Axelrod already talked about the increased risk with age. Breast cancer risk is influenced by family history, genetics, other associated conditions, and we screen high-risk women different than we screen baseline risk women. And breast density, as we pointed out, may suggest that mammography all by itself is just not enough to really give an accurate and sensitive screening for an individual woman. Obviously, the appropriate screening recommendations for any individual woman is something that she should discuss with her doctor. So now moving on a little bit towards prevention. In general, and you're going to hear a lot more about this from Dr. Baez, healthy diet and moderate exercise are associated with a lower risk for cancer in general. And this is not news. And we've known about this for a long time. And we all kind of know what a healthy diet is supposed to look like, and Dr. Baez is going to get into that a little bit more. So that's about trying to lower risk. But we also don't want to take on additional risk. So avoidance of known carcinogens can also lower cancer risk. So we know that cigarette smoking is bad for you and can increase the risk for lung cancer. And there are a couple of other cancers that are associated with specific carcinogens. And just another point specific about breast cancer is that it's now clear that the long-term use of combination hormone replacement therapy, that's including both estrogen and progesterone, in women who do this after the typical age for menopause, which is about age 50, has been shown to increase the risk for breast cancer. So this would be the concept of taking on additional risk, and is something that should be really, really considered thoughtfully, especially in women who are already at increased risk for breast cancer. Now, in addition, there are a number of pharmaceutical agents that have been shown to reduce the risk to develop breast cancer in women who are already at increased risk for the disease. These are all hormonal therapies. The only drug available for premenopausal women is tamoxifen, but in postmenopausal women, the menu of opportunity increases, and it expands to include other drugs like raloxifene or another category of drugs called aromatase inhibitors. And the particular choice for a particular woman depends on a lot of factors, including bone health, et cetera, and that's something that needs to be discussed with somebody who's an expert in the field. The standard treatment is 5 years, and these drugs have been shown to meaningfully reduce the risk for breast cancer in high-risk women. I should really emphasize that. Each of these drugs has specific side effect profiles, and once again, that's something that really requires a conversation with someone who is an expert in the field. So just to wrap it up, I think I made 10 points that I hope I made clearly and that you're going to take away from this discussion. In the short period of time, obviously, we can't discuss everything, but these are some big take-home messages. So one is that screening for breast cancer focuses on early detection of the disease. And two, the benefit of early detection is obviously a better outcome from the disease, but also less disruptive treatment methods, potentially less surgery, avoidance of certain drugs like chemotherapy, et cetera. We think that breast cancer risk assessment is important for adult women because it helps them, with their physicians, make a plan for the appropriate screening and prevention recommendations that are individualized based on their risk. But beginning at age 40, we think that women should be screened for breast cancer, even in baseline risk individuals. But screening should also be influenced by an individual's age, their background risk for breast cancer, and let's not forget breast density that may argue for additional imaging beyond mammography. Mammography alone is not an optimal screening method for women with dense breasts, and again, consideration should be given for supplemental imaging. Breast cancer prevention is important because this is an effort to reduce the incidence of the disease and to decrease the burden that breast cancer presents for both the patients that are affected, their families, and frankly, society as a whole. Lifestyle characteristics represent modifiable risk factors for breast and other cancers, and we should avoid factors that increase risk unless the benefit certainly outweighs that risk. A healthy diet, moderate exercise, always recommended, and high-risk women can also consider specific breast cancer risk reduction with hormonal agents like tamoxifen, raloxifene, and also aromatase inhibitors.
Are there screening precautions for women with denser breasts? That's your topic. That's Dr. Schnabel's topic, dense breast tissue.
Right, so the message for women with dense breasts is that mammography all by itself is not really an optimal way to do screening, and that women with dense breasts should also be considered for additional screening with ultrasound, and certainly in higher risk women, potentially even MRI.
Okay, and when should someone stop screening?
That's a great question. That's a great question, and I don't have a very firm answer about that. My thinking here is that the reason I don't give a specific age cutoff is that people age differently. And some people age very well. I have patients in their 80s who play tennis. And some people develop chronic conditions and other disabilities that really limit their life expectancy and so on. And I think all those things have to be taken into consideration. But certainly, for women, once they get to the late 70s and 80s, even if they're in great health and we think they should be screened, we can do it differently. We can increase the interval between screens. Potentially, if the breasts are not dense anymore, we can take away some of the supplemental methods and so on. But I don't have a really easy answer to that question.
Okay, here's another. Oh, this is this interesting question about baby tamoxifen. So versus grown-up tamoxifen. So baby tamoxifen, we hear about that at our meetings. It's, it's talked about more and more. What do you say to someone who doesn't want to go on the full dose tamoxifen if they have lobular carcinoma in situ or atypical duct hyperplasia or some other risk factor?
I think it represents a terrific option. at this point, so now the typical dose of tamoxifen is 20 milligrams a day. Baby TAM is like 5 milligrams a day. And at this point, we have 10-year data on the baby TAM studies that seems to indicate that the prevention benefit is the same as with the full dose, but the side effects are much lower. So I kind of think this is a wonderful option. Historically, the vast majority of high-risk women have declined to take tamoxifen, mostly because I think concerned about side effects. So if we can come up with this method where they still get a good prevention benefit without the same side effects, I think a lot more women may consider doing this treatment.
When would you recommend an MRI?
So the American College of Radiology recommends that women should be screened. Remember screening? Somebody asymptomatic for early detection, that women who have a greater than 20 to 25% lifetime risk for breast cancer should have MRI potentially included in their screening. And that 20-25% can include a lot of different things, including patients with a condition called LCIS or atypical hyperplasias, certain elements of family history, etc. But the one group where screening with MRI is very solid and I think agreed to by all is women with genetic mutations, as in the BRCA1 and 2 genes, where they have a very significant higher lifetime risk for breast cancer. And we certainly recommend annual MRI to those patients, alternating with mammography. So you do a different test every 6 months.
Good evening, everyone. I'm Dr. Pak. I'm one of the breast surgeons at NYU. I'm very excited to be joining everyone tonight and chatting about breast cancer genetics. Next slide. So just an overview of the 3 areas that we're going to talk about today. We're going to talk about who should have genetic testing, what is genetic testing, and then why is it performed. So first, who should have breast cancer genetic testing? So we have a couple criteria that we use, and these are recommendations that come from national guidelines from the NCCN. That in general, patients who are diagnosed with breast cancer at age less than 50, as previously mentioned, the median age for breast cancer is women in their 60s. So when women are diagnosed at a younger age, we ask ourselves, is there an underlying genetic mutation that may have predisposed them to develop breast cancer at a younger age? And we also recommend doing genetic testing in patients who are diagnosed with breast cancer at any age who fulfill any of the additional following criteria. If it's diagnosed in a male, if it's diagnosed in a person of Ashkenazi Jewish ancestry or descent, because we know that these genetic mutations associated with an increased risk of breast cancer have higher incidence in patients of Ashkenazi Jewish ancestry. We recommend genetic testing in those diagnosed with certain types of breast cancers, including triple negative breast cancers, regardless of age. We also recommend genetic testing in patients, again, with a certain type of breast cancer, a lobular breast cancer, who also have either a personal or family history of gastric cancers, because we've seen a link between this type of breast cancer as well as gastric cancer, stomach cancer. We also recommend doing genetic testing for patients who develop multiple breast cancers at the same time. For example, if an individual develops breast cancer in both breasts at the same time, because we know that breast cancer doesn't spread from one breast to another, so that happens at the same time, one on each side, which we refer to as bilateral breast cancers. That's 2 completely separate breast cancers. And also if women develop additional breast cancers, for example, they've had a history of breast cancer and they now develop a second or potentially even third breast cancer that we know is not a recurrence of the initial, but truly a new breast cancer. That also, we recommend doing genetic testing. And we also look at people who have breast cancer who also come with certain family histories, even if they themselves have no personal cancer history, because some of these genetic mutations are associated also with increased risk of pancreatic cancers, ovarian cancers, prostate cancers, and they could present that way in certain family cancer histories as well. And then there are also individuals who don't have breast cancer who are considering doing breast cancer genetic testing. And that again is patients with personal history of certain cancers, particularly ovarian cancers, and also if they have a family history of certain cancers. Again, as I mentioned, family history of breast cancer, ovarian cancer, prostate cancer, pancreatic cancer. Some of these are often seen in what we call syndromes that are associated with certain breast cancer mutations. And so in general, if there's ever a question whether you're somebody who has been diagnosed with breast cancer, or if you're somebody who does not have a diagnosis of breast cancer and you're wondering, should I have genetic testing? It really does require individualized discussion and a risk assessment with your physician, and that can be done, beginning with your primary care physician, with your gynecologist, and going from there. So the next part that we'll cover is, what is genetic testing? So genetic testing is an evaluation for a genetic mutation that may increase one's risk of breast cancer, as well as potentially other cancers. And what this is really looking for is, it's looking within somebody's DNA sample and looking for particular changes in very specific genes that we know that some of these changes may be associated with an increased risk of developing breast cancer in the future. So there are a couple of steps involved in genetic testing. So usually it begins with first a visit with a genetic counselor, and this occurs before the actual testing. The genetic counselor will go over the individual's personal history and family history, particularly of cancers, as well as any prior available genetic testing results that may be available from within other members of the family. They'll discuss testing options. There's a wide array of different types of panels that are available. They all will include at least some of the most basic genes that are associated with the increased risk of breast cancer, but some of them also come with the option of very, very extended panels that can include, potentially hundreds of genes, and that will be something that the individual patient can decide if they choose to do with a genetic counselor or not. And then the genetic counselor will also talk about some financial considerations in terms of costs, insurance coverage, and sometimes patients will have questions about what these results may mean for their ability to obtain insurance or things like life insurance, that kind of thing. And that'll be something that can also be discussed with a genetic counselor. After the initial pre-test visit with the genetic counselor, then comes the actual testing. And this can be done either with a blood test or with a saliva test, like for example, a swab. And often this is something you can even do at home, and then send the testing kit into the testing facility. The results on average can take about 2 to 3 weeks to come back. And then after the results come back, you will have another meeting with the genetic counselor to talk about the results and talk about what it means and then any potential next steps that need to be taken. So as I mentioned, there are various gene panels available. Within breast cancer, there are certain genes that we specifically look for. Some of these you may have heard about. The most common one that is often mentioned is the BRCA1/2, or otherwise known as the BRCA1, BRCA2 gene mutation. There's also PALB2, TP53, CHEK2, ATM. As I mentioned, there's a wide array of different tests and gene panels available. All of them at minimum will be covering all of these high risk genes, in addition to some the extended panel of genes that may also be available. And then in terms of the results that you're going to get, you're either going to get a negative result, which suggests that you have no mutation in a gene that's known to be associated with breast cancer. You may have a positive result, and it will identify which mutation in what gene you have tested positive for that's associated with increased risk. And that's important information because depending on what type of mutation you have and what specific gene, that will help your doctor to determine exactly what your risk is moving forward. It's very different depending on which genetic mutation individuals has positive for. And the last is something called the VUS, which is an acronym that stands for variant uncertain significance. And that just means that the individual has tested for a mutation in a gene, one of these genes, but we're not currently sure exactly what that alteration in that gene means. From a perspective of science, just doesn't know at that point. We just don't have enough information to tell us, does this alteration mean that this increases somebody's risk? Does it decrease their risk? Does it not do anything at all. And so we just don't know. And what I usually tell patients when they have this kind of result of a VUS is to just keep in touch with our genetics team every couple of years. You can give them a call back and say, I had my genetic testing done. 5 years ago, I had a VUS. Has this been reclassified? Which means, has any more information come out over the intervening years that suggests that maybe this is now a benign mutation and doesn't really increase any risk, or has it in fact been reclassified as something that does increase my risk of breast cancer, in which case that would be important to know. And so the last part we're going to cover is, why is genetic testing performed and what implications this may have for an individual's care. So I'm going to break this down into two categories, because how we use genetic testing is different depending on if this is a person with breast cancer or if this is a patient who has no diagnosis of breast cancer. So for patients who are diagnosed with breast cancer, genetic testing is performed to help personalize their breast cancer treatment. And there's two main areas that we think about this. And one is thinking about the extent of surgery. There is surgery that we do for treatment of the current breast cancer, and then there's also surgery options for future risk reduction. For example, we know that if you have a genetic mutation, it does not change how well you do from your current breast cancer. Patients do just as well in terms of their outcomes from their current breast cancer, regardless of whether they have a genetic mutation or not. But we do know that if a patient has a genetic mutation, they have an increased risk of developing additional breast cancer, a second breast cancer in the future. And so in some cases, patients will opt for more extensive surgery, both for treatment of their current breast cancer and also to reduce their risk of developing another breast cancer in the future. The genetic testing results also factors into some of the medications that we use. So that refers to systemic therapies. That's medications that are used to treat breast cancer throughout the body, okay, and reduce that risk of it coming back in other parts of the body. And there are certain medications that are specifically targeted for specific genetic mutations, and you'd only be eligible for that if you had certain results of the genetic testing. And then again, after the treatment of breast cancer, we also think about how to tailor future breast cancer screening in women who are diagnosed with breast cancer. As Dr. Schnabel has referred to before, if there's an option for high-risk screening with MRIs, and that's an option that we will potentially discuss and utilize in patients who we know are additional risk of breast cancer in the future. And then also to tailor the screening and management of non-breast cancers, but other cancers that the patient may be at increased risk for, in addition to the breast cancer, and that includes ovarian, prostate, and pancreatic cancers. And similarly, for patients who do not have a diagnosis of breast cancers, the implications for screening are very similar, talking about whether there's a need or indication for high-risk screening with breast MRIs, and also tailored screening and management of non-breast cancers. But a key point is also the earlier initiation of screening. As Dr. Schnabel mentioned, we currently recommend for baseline risk women starting breast cancer screening at the age of 40, but in certain high-risk groups, sometimes we even move that time up to the age of 25. And again, for women who do not currently have a diagnosis of breast cancer, there are options to reduce the risk of developing a breast cancer in the future if they're found to have a genetic mutation that significantly increases the risk of breast cancer. The first is the medications that Dr. Schnabel mentioned, which we refer to as chemo prevention, and also even consideration of risk-reducing surgery, which would mean for women who are considering this option would mean bilateral mastectomies, removal of both breasts as a preventative measure to reduce their risk in the high, and that's usually an option we really reserve for the highest risk category of women.
How often should I get genetic testing?
So it really depends on the panel that one elects to get. And I think in the last probably 5-10 years, there really hasn't been a whole lot that's changed. Sometimes the patients have had very limited panel testing before. I think maybe in the last, if you look back, probably 15 years or so, women were probably some women were only getting the BRCA1 and 2 gene being tested. So it really depends on what type of panel testing the person had. And so for patients that I see who've had prior genetic testing, regardless of when it was, I always ask them to bring their prior results in. And if it really is a pretty comprehensive panel, and that it's covered all the genes that we would test for now that would make a significant difference in either treatment or their screening, then I say it's fine. But if it looks like they had a very limited panel, for example, they only got tested for the BRCA1 and 2 gene, 5 or 10 years ago, and they really didn't get tested for any of the other ones, I'd recommend they repeat the genetic testing.
What is the youngest age you can test someone?
Yeah, I'm not really sure if there's a actual cutoff for the number. That I'm not sure. But as I mentioned, the earliest that we really think about any changes in terms of screening is that starting at the age of 25. So there's really it doesn't really make a big change in how a patient is managed if they get tested before then. I think the only exception to that would be if somebody comes with a significant family history of incredibly young breast cancers or other cancers in their early 20s, where they may consider doing something different. Then I'd recommend doing it at a much younger age. But I think since our screening recommendations really don't change until the age of 25, and for the highest risk patients, I think sometime in the mid-20s would be completely appropriate.
Yeah, but I think also when you look at some of the adolescents who have, these MEN, these types of syndromes, cancer syndromes in their family, I think that's where we would recommend adolescent testing. What's the recommendation for these commercial tests to segue into validating that test? Would you then send them to a genetic counselor, a high-risk specialist, someone like Dr. Smith?
Mm-hmm. Yeah, so I've seen a couple of these patients too have had a 23andMe test that have shown a mutation that's increased their risk of breast cancer. And for those, I recommend they repeat our formal genetic testing with us to confirm.
We're very happy to have Dr. Anthony Baez, who is our breast surgery fellow this year. He comes to us from Northwell Health. He is our numero uno pick. We're very happy to have him. And he's going to talk about eating to reduce breast cancer risk. And he's going to throw in a little alcohol and a little exercise, right? Okay.
That's correct, yes. All right, so again, I'm Anthony Baez. It is such a pleasure to be part of this webinar. It's been very informative so far, so I hope I can also contribute some of the education. So next slide. Okay, so we are going to discuss what exactly is healthy eating, what we mean by that phrase, and then we're going to delve into the different food groups, and we're also going to discuss a few common questions that come up in the office from patients, and then we'll talk about exercise, and I will also include a little discussion about alcohol. So what exactly is healthy eating? So this is really the question that people have been trying to answer for a very long time. And for this reason, a lot of different diets have emerged, including some things that you guys may have heard before, such as the paleo diet, the Atkins diet, the keto diet, and the list goes on and on. But the key really is to have a diet that has nutritional variety. And what we mean by that is the ideal diet will include various different macro and micronutrients, including proteins, carbohydrates, fats, vitamins, and minerals. And then the other question is, so why do we care? Why does this matter? And what we have learned is by healthy eating and by adding variety to our diet, it actually positively affects our immune system, it improves our mood, it increases our energy levels. But it is very important that I emphasize that there is no specific food that can prevent cancer. And another thing that is also important to note is obesity and being overweight has been shown in many previous studies to be associated with an increased risk of primary and also recurrent breast cancers. So it is not just about getting those macronutrients and those micronutrients, but also by eating healthy, we can maintain weight goals and therefore that has tremendous amounts of health benefits, including a reduction in the risk of breast cancer. So the graphic on the left is probably very familiar to most of us online. It is the classic food pyramid that was created in the 90s, and it was everywhere. And it essentially is a representation of what, quote unquote, was the ideal proportion of different food groups in a daily diet. And as we can see here, there was really an emphasis to really, focus a lot on the grains and less so on the fats. And the recommendation was to use fats sparingly. But with time, we have learned that not all fats and oils are the same. In fact, there are many fats, many oils with tremendous health benefits, particularly those that are derived from vegetation. So then the USDA decided to change this, throw the pyramid out, and created this graphic on the right, which is my plate. And my plate is not the best representation of what an ideal diet should be, but it is much, much better. And as we can see, there is an increased representation of fruits and vegetables in this new model diet. So this brings us to fruits and vegetables. So the American Cancer Society and the American Institute for Cancer Research recommends 5 or more servings of vegetables and fruits per day to minimize cancer risk. And the reason is because, well, first of all, these are foods that for the most part are not very calorie dense, but include tremendous amounts of minerals. And I included this photo of the strawberry down in the bottom of the slide because this simple small strawberry, it has multitude of different vitamins, including vitamin A, which is great for the vision, B1, B2, B6, vitamin C, folate, and these are all very important vitamins that allow us to enhance our immune system and other bodily functions. And I want to make it clear that I did include this slide and I titled it Rainbow Diet, but I'm not trying to push another diet. I'm not trying to monetize a diet by any means. This is just a term that I created to help us remember that a way that we can think of eating in order to maximize the amount of nutrients that we get from food and increasing the diversity of food that we consume is trying to add color to our diet. Include leafy greens, include really, foods of all different colors because they all have their own different properties, their own nutrients. And by really maintaining or trying to replicate a rainbow diet, we are really maximizing health benefits through eating. So then this takes us to whole grains. So whole grains, they are different from refined grains. And the reason why is because whole grains, they maintain the core of the grain kernel, which contains fiber, minerals, and vitamins. And the USDA recommends 3 to 4 ounces or more of whole grains per day. So essentially stay away from the white rice and white bread and opt for something a bit more nutrient rich, such as oatmeal, multigrain bread, and other essentially wheat whole grain products. And my favorite is protein. Protein is very, very important for many different functions, including muscle development, muscle growth, as well as healing. And the USDA recommends 7 ounces per day. And another way to think about this is 0.75 grams per kilogram of body weight. And meat is an excellent source of protein. However, it is important to note that meat comes in different cuts and different varieties. So if we're going to use meat as a source of protein, it is important to opt for leaner cuts. And another source that is, or other sources that are leaner just by default are fish and poultry, which are excellent choices. And eggs, I consider eggs to be really a superfood. It has truly a tremendous amount of nutrients and is also high in protein. But for those who are opting for vegan or vegetarian diets, beans, nuts, seeds, and other products have been shown to also be high in protein and can supplement this need. So milk and dairy. The USDA recommends 3 cups equivalents per day. This can be milk, soy milk, yogurt, cheese. However, not everyone can consume milk and dairy for various reasons, and therefore there are other supplements that come from nature, essentially, which are carrots, sweet potatoes, broccoli, leafy green cereals, and really many other things can provide the nutrients that we extract from milk and dairy. And then there are fats and oils. And as I mentioned in the beginning of the presentation, we've learned more and more that not all fats and oils are the same. And when we opt for introducing fats and oils to our diet, it is important that we stay away from saturated fats as much as we can. These are things that are commonly derived from animal products. And we try to maximize the amount of monounsaturated fats, so things that are derived from vegetation, fish, and nuts. And then some common things. So or rather common questions regarding diet that often come up in the office. One of them is regarding soy products and foods that may contain estrogen-like substances. And soy products in particular, so they contain isoflavones, which have estrogen-like properties. And theoretically, this has raised the concern that this could increase the risk of developing breast cancer. However, there have been many studies that have looked into this, and actually, there also have been a review of all of these studies. And what we have learned is there doesn't seem to be a direct correlation. In fact, some of the reviews have demonstrated that there may even be a small benefit to consuming soy products, but in reality, that's probably most likely due to just healthy eating habits in general. But it is safe in moderate doses to consume soy products. It is not a problem from our end. And then the other question that comes up a lot is regarding sweets. There is a lot of thought out there that sugar, in particular simple sugars, can feed a cancer. And I'm here to say that there is no hard evidence to prove that. In fact, there have been studies that have looked at simple sugars, such as simple sugar beverages, as well as beverages that contain artificial sweeteners, trying to establish a correlation between these and the risk of developing breast cancer, or cancer in general, rather. But these studies have really been inconclusive. So even though we don't have any hard evidence to suggest that these are tied to cancer necessarily, overall, there's a lot of health benefits that we can get from trying to reduce or even eliminate these from our diet, as they are not very nutrient dense. So my suggestion would be to limit sweets as much as you can. And this really is for everybody. And actually, before I get into exercise, because I missed this in this when I was creating the slides, is I wanted to touch upon also on alcohol. So this is also a common question that comes up. Can I still have a drink? And what the studies have shown is even some low dose or low consumption of alcohol has a very, very mild impact on breast cancer risk. This is about 3 to 6, and I want to make sure I make this clear. What this has been classified as 3 to 6 drinks per week. And this has been tied to a very small increased risk of breast cancer, approximately about 15%. But the greatest risk for alcohol consumption during or in relation to breast cancer really has to do with heavy drinking, and it has a cumulative effect. So the longer you're drinking and the heavier you drink, that is associated with an increased risk. And there's also been an independent risk association between those who consume alcohol at very early and very late ages that has also been associated with a mild to moderate breast cancer risk. So now coming to the slide, exercise, I believe I said it before, but no conversation about nutrition is complete without discussing exercise. There is really just a multitude of benefits that we can derive from exercising, from moving our bodies. And it's not just physical benefits, but it's also psychological benefits. And there have been many studies that have shown that exercising increases mood, it increases energy, and it increases also quality of life in breast cancer patients and survivors. And the physical benefits, they're very well known to most of us, which include cardiovascular benefits, bone health, which is particularly beneficial in breast cancer patients, especially those who may need to take certain medications that affect their bone health. It improves our overall fitness. And I mean, who doesn't want to be more fit? And also, there have been studies that have shown that in patients who have something called lymphedema, which is essentially arm swelling that can occur from certain surgical or radiation procedures, there actually is a benefit in terms of reducing or preventing lymphedema or arm swelling in these patients.
Does the type of alcohol matter? You know, grain, beer, whiskey, wine?
So yeah, that's a great question. And the important thing to know is different types of alcohol have a different sort of alcohol density to them as well. So of course, a cup of beer is different than a cup of hard alcohol. But really, what matters is the alcohol content. I don't know in particular if there is, or at least I didn't see from my own investigation, whether there is a particular association with certain, grain beverages and such. But the important overarching theme is really the quantity of alcohol. And as I mentioned before, it has a cumulative effect.
What do you think about organic foods?
So that's a good question as well. And it really matters what is the definition of organic, because I think that that's also something that has been up for debate and questioned many times. There hasn't been any specific literature or study that I've encountered, or so I don't have much data to back up whether it is beneficial in terms of overall cancer risk. But I will say that it seems theoretically plausible that by minimizing the amount of substances that are introduced into our foods, essentially that should have some health benefits. But I don't have any hard data in regards to cancer regarding organic foods. And then the other thing is, I think there was a question also on GMO, which kind of goes along with that. There really hasn't been any studies that I've also have encountered that have really established that correlation between those foods and cancer risk.
Do you think that there's like an ideal diet that someone should be encouraged to go on if they want to lose weight, if they want to eat healthy, if they want not to yo-yo?
So that's a good question. And actually, there have been some studies that have shown that there's a lot of benefit to maintaining sort of a Mediterranean diet. I've seen that before. But in reality, what it really comes down to is when you think about Mediterranean diet and what it consists of, is really maximizing the amount of nutrients that we derive from fruits and vegetation. So sort of, reducing the starches, trying to derive our protein from clean and lean sources such as fish and poultry, and really, introducing more fruits and vegetables. And I think that will contribute to the most balanced diet that will allow us to maintain and enhance our weight loss goals, but also help us in terms of cancer risk reduction.
We are going to be talking about the top 10 questions to bring to your doctor when diagnosed with breast cancer. Dr. Guth is the director of our breast fellowship, and you just heard from one of our fantastic breast fellow. Dr. Guth runs the program. So I'd like to now introduce Dr. Guth, who's going to be delivering this talk. Thanks, Anthony.
Yeah. Thank you, Anthony, for an outstanding talk. It brought a lot of clarity to a very confusing issue, and it's very helpful, I think, for our audience because there's so much contradictory information available in the media and on the internet. So I think this was right on. So thank you. So a little bit of a tough act to follow, but we'll give it a try. And I'd like to thank the audience for hanging in here, being patient with us as we try to bring this information to you. So our last topic is 10 questions to discuss with your doctor when you're diagnosed with breast cancer. Next slide. And let me go through first what these 10 questions or perhaps questions is the wrong word, but topics to discuss with your physician when you're having your initial consultation. What type of breast cancer do you have? What's the size of the cancer? What's the location of the cancer? Do we know whether this is spread to lymph nodes or other organs? What's the stage of breast cancer? And what does staging mean to me in terms of prognosis and treatment? Will I need additional testing? Do I need to see other doctors or health professionals? Then talking about the specific cancer itself, what's the hormone receptor status of cancer? What's the HER2 status of the cancer? What's the grade of this breast cancer? What do all these factors mean? And how do these factors affect my treatment and long-term outlook? Notice we are not asking the questions we hear sometimes. Where did you train? How many breast cancers have you done in your lifetime? Are you a breast cancer specialist? I expect that when you're visiting your doctor, you will have already done some of your homework and picked out somebody who is appropriate for your care. Running the breast fellowship here, obviously, you want someone who's a dedicated breast physician, whether it's your surgeon, whether it's your medical oncologist, because this way your care provider has the expertise and the latest knowledge. So we're not even going to that question. But let's talk about what questions will be helpful for you. First, what type of breast cancer do I have? And breast cancer can be divided into a number of different categories. One category is whether this is invasive or non-invasive breast cancer. Non-invasive breast cancer is also called in situ carcinoma, stage 0 breast cancer, or ductal carcinoma in situ. All names for the same process, which is essentially a precancer. Lesions that have cancerous appearing cells under the microscope, but not cancerous organization under the microscope. If this is an invasive cancer, there are different subtypes, including ductal type, which develops in the main milk ducts that drain the breast, or the lobular subtypes, which are more at the periphery of these milk ducts. And these cancers can act in different ways. So these are very important distinctions to know and to understand. How big is the cancer? And this can be difficult depending on the type of breast cancer that you have. Before surgery, these measurements depend on breast imaging that we get. Mammograms, ultrasound, breast MRI, can also be based on physical exam. All of these measurements can either overestimate or underestimate the size of a breast cancer. So for definitive staging and sizing of breast cancer, we really depend on the surgical pathology specimen and the measurements given to us by the pathologist. Where's the cancer located? This can help us determine best treatments in terms of cosmetics. It can help us understand which lymphatic drainage systems are at risk, because the outside of the breast will drain to a different part than the inner aspect of the breast, for example. We have more breast tissue in the upper outer breast, and thus the majority of breast cancers diagnosed are actually diagnosed in the outside, upper outer part of the breast itself. Has the cancer spread to my lymph nodes? Lymph nodes are parts of a body system of filtering organs. We see them under the arm, we see them in the chest, we see them in other parts of the body. Their job is to filter out dangerous dangerous objects that may harm us: chemicals, bacteria, viruses, cancer cells. When the axillary lymph nodes, for example, filter out a cancer cell, they react to it, they swell, they enlarge, the size changes. So these lymph nodes will look different on imaging than normal lymph nodes do. And that can be a very good first indication that the cancer has spread outside the breast into the lymph nodes. This does change the staging of the cancer, depending on the type of cancer and how many lymph nodes are involved. This may or may not change medical treatment of the cancer itself. So particularly for some of the more low-grade breast cancers, having a cancer in the lymph node may not necessarily guarantee you'll be recommended chemotherapy. But very important part of understanding the biology of your specific cancer. What's the stage of my breast cancer? And this is a question that most newly diagnosed breast cancer patients will get asked by friends, relatives, trying to figure out how severe the cancer is, what the treatments are, what the prognosis is. And you can see from the schema here that the majority of our breast patients actually do quite well. Stage 0 and stage 1 breast cancer, stage 0 being non-invasive breast cancer, stage 1 being early stage cancer without spread to the lymph nodes, has approximately 100% survival. Once we see involvement of the lymph nodes, the survival drops some, but is still very good at 87%. More widespread cancers, again, don't do as well. And these are somewhat older numbers for metastatic or stage 4 breast cancer. And for all comers, we really expect these patients will do better than 20% survival. So that's a bit of an old and out-of-date number. As Dr. Axelrod put so nicely in her introduction, our patients overall do well. And we have a very large population of breast cancer survivors here in the country. Will I need other tests before deciding on treatment? And again, this will depend very much on personal issues and breast cancer specific issues specific to your case. And everybody is approached differently. This is a very much an area of individualized treatment and personalized care. So what may work for your neighbor may not be the right answer for you. As was mentioned above, roles for genetic testing, roles for other tests such as breast MRIs, and this you will need to discuss with your physician and decide what's correct for you and your situation. Do I need to see other healthcare professionals? Breast cancer these days is treated with a multidisciplinary approach. This is a team effort. This is not one physician taking care of our patients, but a group of dedicated breast physicians working together to provide the most up-to-date and most effective care for our patients. And the team includes breast surgeons, very often we're the entry point into breast cancer care, but also our colleagues in medical oncology, radiation, perhaps plastic surgery, working very closely with our radiology and pathology colleagues. This interaction between all of us is very important to help understand your breast cancer best and figure out which is the best care for you. There are physicians and healthcare specialists who can help you afterwards, including perhaps need for physical therapy. Breast cancer is a very stressful and trying situation, both for the patient and for family and family members and friends. So social work, psychiatric support and help are all part of this. So it really takes a village to take care of a breast cancer patient. And again, we have so many questions and things to go over. So I'm jumping over a fair number of different facts here. This will be available on YouTube, so you will be able to go back and go over these slides and go over some of these things we've discussed, because I'm throwing an awful lot of information at you in a short period of time, and particularly at the end of the session here. But hormone receptor status is one of the most important pieces of information for understanding your breast cancer, because this tells us what type of breast cancer you have. All breast cancer is not the same. It's not all treated the same. And understanding the personality and biology of your cancer is crucial to understanding how this cancer will behave and what are the most effective treatments for taking care of your cancer. So we look at what are called the hormone receptors. This is sensitivity of the cells to the female hormones, estrogen and progesterone. There are other things we test, including what is called the HER2 or HER2 protein. This is a protein that's produced by approximately 15% of all breast cancers. We have very specific and very effective targeted treatments for this type of cancer. These used to be considered very aggressive cancers, but with these targeted treatments available really since about the year 2000, the management and outcome of these cancers has changed completely. And as our treatments have become clearly very effective, we're beginning to be able to scale down on some of our treatments for these HER2 positive cancers. And again, this becomes a very individualized treatment for the HER2 positive breast cancers. Some patients will be recommended treatment before surgery. Sometimes you'll need your treatment afterwards. Some patients will also be recommended chemotherapy, but these days we're beginning to be able to step away from that a little bit. So it's a changing field, but overall, these patients can do very well. Cancer grade. This is telling us how aggressive and how angry or active the cancer looks under the microscope. An important piece of the puzzle, but again, the biomarkers are very, very important. Lymph node involvement is very important. So this is one data point, but not the data point. And again, just phrasing this a little bit differently, but showing you what we expect for outcome and survival. Again, for cancer localized to the breast, stage 0, stage 1, 99% 5-year survival. For cancers that are involving the lymph nodes, see about an 86% survival. And for metastatic breast cancers that spread outside the breast and lymph node areas go into other parts of the body, approximately 30%. Metastatic cancer is a small percentage, thankfully, of all the breast cancers we see in this country. So if you put all this together, our overall survival, again, as Dr. Axelrod mentioned in her introduction, is about 91%.
How do you stage breast cancer if you have chemotherapy first? I think that's actually an interesting question because we are giving a lot of chemo first.
Yes, and it's staged differently. This is really a very descriptive staging in terms of how much cancer is left behind in the breast, how much cancer do we see in the lymph nodes. There are protocols for describing how much of the cancer has been killed by the chemotherapy, and these are being used more and more by the medical oncologists in describing what they see. An important piece of it is descriptions, and the pathologist can tell us whether they essentially see dead cancer cells on the pathology. And if we see what's called a complete pathologic response, where all the cancer has been killed by the chemotherapy, these patients have an excellent prognosis. But it's very much a descriptive process. How much cancer was killed? Was it all killed? If not, is there a little bit of it left? Is there 5% of the cells still remaining with 95% taken care of by the chemo? So it gets a little bit more complicated for the neoadjuvant or chemotherapy first patients.
This is really very current. Do you always remove lymph nodes with the diagnosis of breast cancer?
And we don't. We certainly don't. And there are a number of guidelines. One of the guidelines is what's called the Choosing Wisely guidelines, which apply both to breast cancer and management of other diseases as well, trying to optimize outcome and minimize complications or side effects from unnecessary surgery. So this is something, particularly in older patients with low aggressive cancers, particularly in patients who have other very serious medical problems, you really think about what are the pros and cons of doing more extensive surgery.
Put our other hats on and talk about patient-doctor communication. And Anthony, you can chime in as well. You know, like for me, I mean, I've learned so much about being a physician and talking to patients, what to do, what not to do. I would say, you know, if someone said, what's like the number one thing that you would tell a patient when they come and, you know, to a meeting and they're scared, and I would say write down your questions and ask the most important questions first, because you can really get lost in like small pieces of paper, not writing your questions down. I think those are, I think, I think that is something that I would always like to tell someone. I don't always get a chance, but that would be like my number one thing I would tell someone. Do you guys have any suggestions about that?
We have a lot more we have, and our patients have a lot more resources available to them than we used to. You know, these days it's very common for family members or friends to teleconference in to the meetings. You know, my patients will ask if they can tape record the sessions so they can go back and listen to them. With the electronic medical record, patients can go back and look at our summary of our meeting with them and really review our analysis and our recommendations. Very important to have somebody with you so that you have a second set of ears, you have a scribe to take notes. I had a recent physician visit on my own. I went with my husband. I heard one thing, my husband heard a completely different version of it. So for doctors, we can't always focus or understand 100% what's being told to us, because it becomes a very emotional and stressful session for you. So have
Absolutely.
somebody with you.
You know, that brings up a point where I would just spend the entire 2 hours talking about, which is health literacy. And you could be a CEO, you could be, you know, a director of a large organization, and you still can't process the health information that you're given. And I always think back to my dad, who was a super smart guy, he was an attorney, he taught law, he was a professor, and he would always forget to put his batteries in his hearing aids, because I think that he was just so overwhelmed by going to the doctor. I was like,
Well, it's a different language too. It's
Yeah.
like when doctors talk to lawyers, what are they talking about? It's a whole,
Yeah.
it's different words, it's a different thought process.
Yeah.
So it's communication is very important.
Right. Anthony, would you want to say anything about that?
I think the internet is a fantastic thing with a lot of resources, but there are some reliable resources and there are some not so reliable resources. So I think it is important to, when you meet with your breast surgeon or your breast cancer doctor, whoever that may be, to have them direct you to some reliable resources that you can reference after the conversation. Because I think a lot of questions come up afterwards, and you can get very lost in the weeds with all the information that might be outdated or simply incorrect on the internet.
Yeah.
Yeah, two
Well
very
said.
good websites I recommend to my patients are the American Cancer Society website, which has an excellent section on breast cancer, and a website called breastcancer.org. These both websites have a lot of information about breast cancer, also a lot of information about diet, lifestyle issues, very, very reliable, unbiased information.
On Wednesday, January 10th, we're going to talk about, in particular, Dr. Guth went into some of the different types of breast cancer. We're going to go into it now more in depth. Stage 0, triple negative breast cancer, metastatic breast cancer, and then something about clinical trials and diversity inclusion. And then the week after that, which is January 17th, we're going to do more of a surgical talk about surgical options, reconstructive options, moving around tissue to make it look good without having to remove a breast, and then updates in lymphedema, and what Dr. Guth was talking about in de-escalating therapy, that not everybody needs to have everything done. I would like to thank everybody. It was a pleasure. We had terrific speakers. I think we gave out unbelievable information that is going to be on the web. Thank you.